hopefully I can do this topic justice in the next 1 hour. Actually, as we. So, as first off, I wanted to say something that ventricular septal defects is actually different from the ones that we see post-MRI. That we've introduced a term called ventricular septal rupture. And what we're going to do is talk about ventricular septal defects rather than ventricular septal rupture this time around. And as we were doing one case in Penang the last time, when we closed the ventricular septal rupture, one of my colleagues who was assisting me told me, he said that when we close the PSD, the normal ones, it's much easier. So it's actually like a wall with an unfinished window. And what we did is just place the window. But when we dealt with the ventricular septal rupture, it was more like a building that had part of its wall there, and somebody placed a bomb next to it and went off, destroying it. So the wall is actually unstable. That was his comment. I think that's a very brilliant understatement of what he mentioned. The wall is very unstable in ventricular septal ruptures. But in ventricular septal defects, the walls are better. So we will not talk about ventricular septal rupture. We'll go on to ventricular septal defects, the naturally occurring ones. So what we did was, people like classifications. So what they've done in the past is actually classify them from the surgical point of view. And the surgeons like to classify things and make it simple for themselves. So they classify into what they call type 1 to type 4 VSDs. Okay. So what we did is we expanded from there and we gave it names. So Prof. Anderson and his group decided to give it names. So we have the perimembranous defects, which is around the membranous region of the ventricular septum, seen from the right ventricle. And besides that, we have what we call the inlet regions and the outlet regions, as well as the muscular or tubercular regions. Okay, so when we first decided to embark on ventricular septal closure, when I was still in UNISZA Science Malaysia, what we did is we actually conducted a study, because there's no point doing a substrate that you have very little knowledge about. So what we did is we decided to actually look at ventricular septal defects first, and did a cross-sectional study of our patients. So what we did is together with Dr. Swami Hussain, who's one of the lecturers in USM now, he was my undergrad student and then became my fellow colleague. But before that, he was also my MMed student. So what he did is, he gathered all the patients that we had. I provided him the data, and then he analyzed them. So what we realized is that, I'm not sure whether you can see from there, but we had perimembranous defects as the greatest majority. That's the big red part circle. And then muscular defects account for about 30%, with inlet type defects only 2%, and the outlet ones 22%, almost 1/3 of our cases. So similar thing, we just classified them on size. The great majority was small to moderate, almost 3/4. So this was a group that we thought we could tackle safely. We were going to close it by device, and not the large ones. The large ones will live to surgery. So in effect, we had no surgeon in Kelantan, and we still do not have, although recently we got one trainee who was my houseman at the time when I was a specialist. And then I encouraged him to do pediatrics, but he said he was interested in surgery. So I asked him to do pediatric cardiothoracic surgery, and he agreed. Okay, so he's come back, but he's new. So we're starting out some of the surgical programs with him as well. But anyway, what of the natural history? Most got smaller with time. Some remained the same size. Some had to be operated on, and then 16% had spontaneous closure. So if we look at studies done elsewhere from Japan. Actually, this paper appeared in Pediatrics International. It's from a study done in Japan, and they had spontaneous closure occurring in some of the smaller defects, but not in the ones that have congestive heart failure. So perimembranous defects is the largest commonest group. So I'll actually talk about them, and then we'll talk about the outlet VSDs as well, which is our second commonest group. Okay, a few things to know about this defect is that most of our defects, the naturally occurring ones, are this time around the membranous region of the right ventricular septum. And then the muscular defects, we'll talk about them a little. They're actually slight, a lot of the muscular defects undergo spontaneous closure on its own. But some do not, and then we have to tackle those. So when we talk about ventricular septal defects, you need to know the underlying substrate as well. The inner layer, or the what we call the subendocardial layer, has a muscle which is actually doing what we call a right-handed helical turn. And the most outer layer, the subepicardial region, consists of muscles which run in the opposite direction, in a left-handed helix formation. But the center part consists of circumferential muscles, so they allow the heart to pump blood in a sort of circular manner without much turbulence, going from the left ventricle to the aorta. So if you remember that and the concentric nature of the left ventricle wall, then you can understand the concepts of why we run into problems when we started closing these defects. But I've avoided them because I never started using those the devices that they initially used to close the perimembranous defects. So in this slide, we've got anatomical examples showing you actually the membranous septum of the right ventricle. So you can see that the membranous septum sits quite close to the aortic valve. In fact, usually you can get a 2 millimeter gap only. So that presents a problem in itself when you're trying to design a device to close the defect in that region. And the other thing you have to remember is that at the perimembranous region, the bundle of His actually passes just underneath that region. So if you put a defect, so that is another point of problem when you're trying to close the ventricular septal defects, especially the perimembranous ones. Okay, so you have to remember that you're not very far from the aortic valve, and at the same time, you're actually on the inferior border and towards the tricuspid valve. You're actually facing the bundle of His, and where it tends to separate into the left bundle and the right bundle. So this is a diagrammatic representation of that. So you can see, hopefully I don't have a pointer in this one. Hopefully all of you can see that. Do you see that number 2 region? That's your AV node anyhow. And then it passes right very close to the tricuspid valve. And just beside the tricuspid valve is the membranous region of the interventricular septum. So the bundle of His actually passes by very close by. So any device that can impact that region can cause problems at this place. If you do an echo, this is what you see of the. Sorry, the arrow isn't appearing, but you can see the perimembranous defect. If you look at the bottom diagram on your right, RA represents right atrium, LA is the left atrium, and then we have the aorta as a cross section, so it appears as a circle. But at that point, you can see that there's a break next to the tricuspid valve. next to the tricuspid valve, there's a break there. So that represents the perimembranous region of the ventricular septal defects. So when dealing with closures, because of that, and also the naturally occurring part of these perimembranous defects, you can have complications resulting from it naturally. You can have what we call right ventricular outflow tract obstructions due to muscle bundles or a deviated septum. And then you can have left ventricular outflow tract obstructions, again due to deviated septum mainly, or sometimes a growth of tissue into that region from this perimembranous defect. This we can do little about, so they need resection and also surgery. So this group we cannot attempt via device. And then thirdly, they can have valvular prolapse as well. And usually in the perimembranous region, the valve which is closest to the perimembranous defect is actually the non-coronary clasp. So that prolapses. And if you see a prolapse of the non-coronary clasp, then it indicates that it's actually a very large defect. The other complication of this ventricular septal defects is infective endocarditis, and then if it's very large, then they tend to develop pulmonary hypertension as well. Now, muscular VSDs naturally occur in the body, mainly in the trabeculated region, and they can have problems, but generally for us, we divide this into two regions, above the moderated band and below the moderated band. That depends on the approach that we're going to do if we attempt to close these defects. In general, if it's above the moderator band, then we use the femoral vein approach to close these VSDs. And if it's below the moderator band, then we use the jugular venous approach. And then I just put as a warning there, beware the moderator band. The outlet or supercritical VSDs, we'll have examples of them later. These were named variously, including, they were given various names, including infundibular ventricular septal defects, because of that region. So that region above the band of muscle, which you can see from the right ventricle, is called the band of muscle is called the crista supraventricularis. And then below that is trabeculate, and above that is smooth muscle wall. So that region is what we call the right ventricular outflow tract, and also the infundibular region. And it has also been called supracristal region as well, because as it is. So the complications of the outlet VSDs, like you need to know your substrate before you can decide whether it can be closed or not. For a long time it was thought not closable by device because the valve is just there when you're dealing with the outlet VSDs. So because it's at that region, it's just there. If you put a device, it will actually compromise the valve function. So at one point in time, it was thought that these defects cannot be closed except surgically. But we have gone on to prove them wrong. And we have actually closed this type of VSDs as well, back in Kelantan. And then right ventricular outflow tract can occur naturally because the jet is at the infundibular region and can actually introduce some muscular hypertrophy into that region as well. Pulmonary hypertension only occurs in the very large ones. So at echo, this is what you see. So this region is perimembranous. If you see in the short axis, this is your right atrium, left atrium, this is the pulmonary artery here. This is my diagram. Anyway, sorry. So I scanned this picture that I drew. So this region is above the supraventricularis. We call it the subaortic region. And we call this the subpulmonic or the doubly committed because they're committed between the two valves, between the aortic valve and the pulmonary valve. So doubly committed because they're between the two valves. So this is from a paper as well, indicating the effect of the Venturi effect. So I've drawn, because I thought they didn't explain well enough, but we've gone to another paper. And this also tries to explain the phenomenon of the aortic valve prolapse. So you can see as blood passes by, it comes through here, you get ventral effect, it drags the valve, and then as the blood comes into this region, it helps balloon it out, and sometimes because of that it closes off as well. Okay, so in terms of aortic valve prolapse, we classify them into 3 or 4 types. 1, 2A, 2B, and 3. I guess it's not that important, so we'll rush through this region. But 1 means it's mild, 2 more severe, and then obviously 3 is very severe, like in this example with moderate aortic regurgitation. Sorry, like this one. Okay, so when you're dealing, especially with the outlet VSDs, you have to remember, and also the perimembranous defects, that the LV is not a straight wall, actually. It's very nice and circular. So it's elliptical, and in this region, it's even more elliptical. So if you put any device which tries to straighten that part, you're actually going to distort the architecture around it. So this is from the Amplatzer series, and Dr. Zaid Amin. So he went on to talk about why they develop severe complications after putting the device. So in the perimembranous region, remember I showed you that it's actually quite close to the aortic valve. There's only a 2 mm gap away from the aortic valve, usually. If you put a device, and it's very compliant, it will follow the cylindrical nature and not cause anything. But as with most devices they're not compliant, and actually they're quite stiff. So what has happened in fact in the past is they put this device, and it resulted in severe AR because of distortion of the architecture. And you can imagine at this point, the bundle of his passes through. And that has a straightening effect on here. And what I call, when I first saw them do this, I called this actually, aren't they worried about the clamping effect? So you've got 2 discs here, which in fact stretches that bundle and clamps it at this region here, like a wheel clamp. So I've called that the clamping effect. And I'm not sure what, when you're dealing with the ventricular septal defects and you're attempting to close them, you have to remember the substrate you're dealing with. So you have to actually know your enemy before you actually start. You have to remember that it's cylindrical, and you have to remember it can affect the structures surrounding it. So in terms of device consideration, we thought how we could actually do this. And so this is my thoughts on what we can do. So in effect, it's, like I said just now, we have to consider elliptical nature of the LV, the proximity to the valve, and often, especially the outwards ones, you have to deal with the prolapse. Sorry about that. Somehow the video enlarges and changes position. But that's the only way I could get to do this. When I tried with my PowerPoint, I didn't have the codecs to run this, so I had to put it on Linux. So this is actually running a Linux program. So this is a perimembranous VSD. There is a small jet occurring there. It's not very clear, no? And unfortunately, that one didn't show very well either. I'm not sure how we can do this. But if you look carefully, there is actually a defect here, and not only a defect, but there's also a muscular ridge. So that's one of the complications when you're dealing with the perimembranous defects. And because of that muscular ridge, it will eventually slowly destroy the aortic valve with time. So you see, this is actually a large outlet VSD. there's a defect here. And the defect, this is the pulmonary artery coming close by. You can see this is the tricuspid valve. There's tissue here, but there's a large defect in this region. Okay, so this example of outlet or supracrystal VSD, large. It's got multiple defects. I'm not sure whether you can see clearly. There's a large perimembranous defect here. Then there's a muscular defect there. I said, sorry, couldn't show this. So this is a child with multiple ventricular septal defects. So this is anyway a catheter. What we've done here is we tried to close this VSD and we closed it successfully. But this is an example of an outlet VSD. You can see the aortic valve is here. The defect is just at the aortic valve. Right? And it's going out in this region into your right ventricular outflow tract and the pulmonary artery which crosses here. This is an example of how we close a VSD. So this, actually we did two procedures in one. We closed the PDA here, unusual type PDA, but we still closed it. You can see there's a coil sitting here. And then we've passed a wire from the right ventricle IVC through the defect and into the aorta. Then we've this is the device coming out. Okay, so the device is now sitting in the perimembranous VSD defect with an aneurysm, and we've closed it. We have none to go. I know it's not easy to capture, but just have a quick look. PDA again, very unusual type. So we did two procedures in one, and all within 2 hours. VSD here, you can see the right ventricle filling. Fast state through the defect. Delivered the device. And then we closed it. See, no more passage to the right ventricle. So the next one is actually a larger perimembranous defect, and here we've actually used PDA occluder to close it. So you'll notice that the PDA occluder has a large base here, but it doesn't have a right ventricular disc. So in fact, when we did this, we thought that this would be a safer option than actually the double disc devices. So we've used it, we released it, and again we closed the defect. Almost closed, but by the next day, nothing was seen on echoing across the defect. This is because this defect was actually larger, so we couldn't use the earlier device because the size limitations on that device. So the PDA device actually it goes up to 16 by 14. So we can actually close a defect that's 14 millimeters or less.